Now we go with our second speaker. It's Katherine Zukotynski. She's a PhD, MD, professional engineer. And Katherine is a nuclear medicine physician and radiologist, as well as a professional engineer. She is a professor at McMaster University in Hamilton, Ontario, with several affiliations and a special interest in theranostic, prostate cancer, as well as dementia. Katherine, the floor is yours.
Thank you very much. Can everybody hear me?
Yes, clearly.
Wonderful. Thank you. So without further ado, let me talk a little bit about building access to PSMA targeted RLT across Canada. Okay. So in terms of my disclosures, I have received support from Novartis, General Electric, in vitro and fusion pharmaceuticals. And I thought I would start off by talking a little bit about the need for accessible imaging. So when we talk about imaging in prostate cancer, sadly today, I would say still, we go to transrectal ultrasound in men suspected of prostate cancer after a PSA and DRE, where trust with biopsy is the next step. And the MRI is really done to inform biopsy in stage men with prostate cancer, particularly those with intermediate to high risk of extension beyond the capsule, and to reevaluate men deemed to be suitable for active surveillance based on PSA trust and biopsy. Still to this day, standard of care imaging typically for men at risk of spread is a diagnostic CT and a bone scan. That was put together by the CUAJ in 2020, and I believe it still remains true today. And what is somewhat sad when we talk about the pan-Canadian approach is the wait lists, even for MRI, CTs, bone scans, and ultrasounds, have grown thanks to the COVID pandemic and lack of staffing. Now, when we talk about PET, I would say PET is a beautiful thing. For example, if you look at this routine TEC MDP bone scan that was done and you compare it to the sodium fluoride PET that I'm showing you here, you can see that metastases that were actually only suspected on the technetium MDP bone scan are very clear on the PET study. And then not only did our equipment improve when we looked at our PET scanners, and it has improved and improved. So now we have time of flight scanners. So too have our radiopharmaceuticals. And so what entered fairly recently, I think I imaged the second patient with metastatic prostate cancer with PSMA PET in Ontario anyway, and that was in 2016. But since that time, we have seen that PSMA PET can show sites of disease we didn't even imagine existed. And there was the whole resurgence of the concept of the Virchow node in prostate cancer. In this particular case, I show you the CT where honestly, it would actually be hard to call all of the sites of disease. And when we did the PSMA PET, in fact, all of the sites of disease above the diaphragm had been unsuspected prior to the PSMA PET. There was much literature that has come out in the subsequent years showing a marked change in management simply based on PET. So now the question is, PET in Canada, where are we? It's true, it's increasingly performed to detect sites of disease at staging and subsequent follow-up. Do we use PET CT or PET MR? I would say across the country, the number of PET CT scanners is still quite limited. Granted, in Quebec, there are a large number of PET CT scanners, but when you look outside of Quebec, they are still very limited in number and access is limited. There are some PET MR scanners, but these are even more limited in terms of where they are, and by and large, they're used for research purposes. In terms of the radiopharmaceuticals, what should we use, why, and when? Well, there are a host of them that I think are quite helpful in prostate cancer. In addition to the PSMA radiopharmaceuticals, there is FDG, and FDG can be quite helpful. Now, when you talk about the PSMA radiopharmaceuticals, you typically either talk about the F-18 labeled or the gallium-68 labeled. In general, they're interchangeably used, although there is some suggestion that you have improved image resolution and the longer half-life makes for easier shipping when you're using an F-18 label. And F-18 DCF-PYL may be more sensitive than gallium-68 PSMA. Not only that, but it might be a little bit easier to read in many ways than the PSMA-1007, which tends to show higher liver uptake and is a little more prone to the false positives. So you have to be a little bit careful how you read, in particular, the ribs when you're reading 107. In terms of Health Canada approval, that's also limiting us in where we're going. So far, the therapy is approved, but the imaging is yet to be approved, and reimbursement is a big question. How will we reimburse this particular therapy across the country? And I think, unfortunately, money is a very important force in how things are brought forward. So when it's a question of who will benefit, I think one of the things that has become more and more apparent is that even at very low PSAs, you get positive scans. I've already mentioned the hepatic activity and the increased false positives with 1007, but the takeaway from this slide is that even with a very low PSA, less than 0.2, 33% of the scans were coming back as positive. So it's really very helpful. In terms of if I could blue sky what we would love from imaging, I would love to have both an FDG and a PSMA PET because much of the disease is heterogeneous and it can be very helpful. And to wit, this is a case I just read, I think, yesterday, in fact, which was a PSMA PET study. And what's interesting in it is that you can see that not only is there disease in the bone, and there is a lymph node that you can see quite nicely in the pelvis, which is hot on the PSMA scan, but there's also a pulmonary nodule, and you see that it's hot on the PSMA scan, and you might think, oh, maybe this is a pulmonary metastasis. Now, how about if I had an FDG scan? Well, that lymph node in the pelvis is not really FDG avid. The bone lesion is very mildly FDG avid, which does suggest there is heterogeneity in prostate cancer. Even at sites of prostate cancer disease, you can get some PSMA avid disease in conjunction with some FDG avid disease. Often the PSMA is more avid when it's prostate cancer, but it depends on how well differentiated it is, how aggressive it is. But what's particularly interesting when you look at this case is that that pulmonary nodule was actually much more avid on FDG. Not only that, but there was a lymph node in the mediastinum. Now, I will tell you that it actually turned out this patient had concurrent prostate cancer and lung cancer. So that pulmonary nodule and the lymph node in the mediastinum were actually lung cancer, and it's path proven. So the question is, how do we manage and how do we adopt a pan-Canadian approach, particularly when there's limited access to PET scanners? Well, you often have to adopt a practical approach, which means it may be very hard to do both FDG and PSMA in all cases. I would say it's virtually impossible in much of this country. So you adopt criteria somewhat like what Vision adopted, which is where you only need a PSMA PET, you don't need the FDG PET, and you try to stack the deck, as it were, to include patients who definitely have PSMA avid disease and those that are more likely to be bad actors, meaning those who have solid organ disease or large lymph nodes, which are not PSMA avid, you exclude them. The one thing also that I wanted to mention on this slide is that actually for Pluvicto, most of the advice was to use the gallium PSMA-11 radiopharmaceutical with the idea that you can use another radiopharmaceutical simply for access purposes. So when we talk about our therapy, what do we need in terms of accessibility? Well, as this has already been mentioned, the treatment that is Health Canada approved on the monogram is for adult patients with prostate-specific PSMA-positive metastatic castration-resistant prostate cancer who have had at least one androgen receptor pathway inhibitor and a taxane-based chemotherapy. There's almost no doubt in my mind that as the data rolls out, the PSMA RLT will become more and more effective even earlier in the course of the disease. How do you do it? It's relatively straightforward. Basically, you can have up to 6 doses, typically spread out about 6 weeks apart, and you keep going unless there is significant disease progression or unacceptable toxicity. What do you actually need? You really need not much more than a disposable syringe with a shield. You need to be able to flush saline before and after. You can give it as a slow push over 1 to 10 minutes, so you really don't need an infusion pump, although if you have one, you can set it up that way. And the time the patient needs to remain in the department is variable and often very little, so less than an hour. We sometimes keep our patients more like an hour, but that's often related to the research protocol that requires you to take vital signs at an hour or later. Laboratory tests, again, they should be quite accessible. These are fairly routine tests that we do across the country. And then in terms of toxicity, so we typically give an empiric dose and we consider extending our interval to up to 10 weeks or decreasing the dose by 20%. To be honest, if we had access to dosimetry, it would be very helpful, but again, this will complicate your administration of the therapy. So what you want to make sure you've got set up, you need to have your radioactive materials license approved for use of lutetium-177. You need to have training for your personnel in terms of handling and using a lutetium-177 compound. You need to calibrate your dose calibrator to measure lutetium-177 accurately. You need to set aside a location for storage and decay. For example, if you order a dose and your patient doesn't come for whatever reason, you have to be able to store that dose. So you have to make sure that you've got enough room on your license that you can maintain a certain amount of activity in the department to accommodate that. Then you need to have educational information, and that I would say is for all members of the team. And you've got to make sure that you've got your information that you can give to the patient, including a wallet card. You need to make sure that you have time and location to do your consultations, both for the patients and preferably with other members of the healthcare team, either through tumor boards or multidisciplinary conferences. You need to be able to get consent from the patient, and you need to have a process for discussing radiation safety issues. You have to have adequate personnel and space, and you have to have adequate access to the radiopharmaceutical. In terms of handling requirements, again, I would say that most places that already handle radioactivity would have all of this on hand. I put here a couple of things just to remember that the half-life for lutetium is fairly long at 6.73 days. The decay via beta particle emission means that, and the way it is taken up means the highest absorbed dose is the salivary glands, GI and GU tract. And to remember, the maximum tissue penetration is only about 2 millimeters, meaning that typically for the patient, once it's been administered, most of it is absorbed within the patient, so you don't actually have to worry if you're up close to the patient. Most common adverse events are, and they're about 30%, fatigue, dry mouth, nausea, vomiting is less frequent, anemia, leukopenia, and thrombocytopenia, again, a little less frequent. You have to make sure that you have access to the facilities. So you should have a room that's dedicated for your therapy and preferably access to a bathroom that is dedicated if possible. You want to make sure your technologists are sitting a little bit separate from the patients. And we like to have at least 3 technologists who are capable of administering the therapy and being involved with the patient who will get the therapy so that we can rotate personnel. Although I would say that the radiation exposure to the personnel is very low. So ultimately, what do I think we need to be able to roll this out across the country? We need to have an effective way of identifying patients who will benefit from the therapy. Now, this requires access to a PET scanner. It requires access to your radiopharmaceutical. I think that we have to start advocating very seriously for more PET scanners across the country and better shipping of the radiopharmaceutical across the country. For example, we had some 8 patients who were supposed to have PSMA PET today when I was covering the clinic, and our second shipment didn't materialize, so we only did 4. We have to make sure that this is a robust supply and that you can count on it. We need to be able to have the means to provide the therapy, to manage the toxicity. Now, I personally think the best way to do this is in tandem with other members of the healthcare team. So the medical oncologists know how to manage toxicities very well associated with much of the same sort of things that we're doing when we're giving RLT therapy. We need to know how to maintain our regulatory compliance and to make sure that we're safe. So what do we really need? We need education. We need good communication. We need preparation and a backup plan. We need access to imaging as well as space to be able to perform the therapy in a safe environment. And we need access to the radiopharmaceuticals and to the personnel, as well as, of course, to the PET scanners, which I've said the imaging space. Of course, we also need time, money, and administrative support. And that's where we really need to start advocating, because we have to make sure that the reimbursement strategy and administrative support is good from the get-go. Many therapies lose out because we don't have this well set when we're going in. And I think this is a true opportunity, because much as Dr. Martineau said before, when I think about where we're going, I think this is just the beginning. I truly think that therapy is the way of the future, and there will be so many therapies that can roll down the pipeline that if we get this right, we can do a lot of good for a lot of people. So I hope this was helpful.
Yeah, well, thank you so much,
you.
Dr.